Okay, well, thank you again for joining us today. We're going to have the introductions and then jump into the meat of the webinar, and that will include talking about cardiac care and hospitalizations and long-term living. We'll talk about some real-life situations and some options for care, the training that's involved, and some of the financial considerations. Again, as I mentioned, my name is Colin Hutt. I'm VP of Operations and Business Development with Spaulding Medical, and I'm very pleased to welcome our esteemed panel to the discussion today, who will be covering the topics. And I'll let Jay Mason introduce himself first.
Thank you, Colin. I'm Jay Mason. I'm Chief Medical Officer at Spaulding Clinical Research. Spaulding is the manufacturer of the Spaulding electrocardiograph, which is now being used in a number of nursing homes and is really the impetus for this discussion. Spaulding also provides a reading service, and it operates a phase 1 unit as well. My background, I'm a cardiologist specializing in electrophysiology. Prior to getting involved in this industry activity, I was in an academic career for some 35 years. I served as director of the cardiac cath labs at Stanford for 13 years. I was head of the Division of Cardiology at the University of Utah for 16 years, and my last academic position was at the University of Kentucky as chairman of the Department of Medicine. And my particular interest is in electrocardiography. Thanks.
Great, thanks, Jay. Liz Jensen.
Hi, everyone. My name is Liz Jensen. I'm the clinical director at Direct Supply. For those of you that may not know Direct Supply, we've been in business for over 30 years, serving solely the senior living and post-acute care settings providers in the United States. We offer a wide variety of services, solutions, and products. And my role as their clinical director, I'm a board-certified gerontological nurse for the last 25 years or so. And my background and my specialty areas have been really focused on education and program development in this space. I consult with clinicians in our profession in both small and large provider organizations on process, practice, and product improvements that improve clinical care capabilities that help drive positive resident outcomes. So I'm in a unique role where I can help kind of match up the things that Direct Supply can offer and do with what our customers are looking to do with improving their outcomes. So thanks for having me today.
Thanks, Liz. Rachel.
Hi, I'm Rachel Rauwerdink. I am the nurse manager at Cedar Community in southeastern Wisconsin. We have 4 subacute rehab beds, or subacute rehab units, for a total of 63 beds. And so I'm just a clinical person who has been using the Spaulding ECG machine and has seen it really improve the quality for our patients, as well as helped us provide better care at the bedside. So I'm just here to help give that perspective.
Wonderful. Thanks, Rachel. And Deb.
Well, good morning, everyone. My name is Deb Hagerty, and I am currently assistant professor at Armstrong State University and also adjunct at Boise State University. And I have spent over 30 years in long-term care as either an administrator or director of nursing. The last 26 was director of nursing at the same company. And I am also the state of Georgia president of NADONA, the National Association of Directors of Nursing and Long-Term Care. So I am very interested in this topic, and I'm excited to be here with you. Thank you.
Wonderful. Thank you, panel. Okay, so just a quick disclaimer here. The materials, comments, and other information contained in this presentation are intended to provide general information, but not advice about certain regulations and initiatives. This information is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. All right, so now that that's out of the way, another quick housekeeping item. This session will be recorded and the slides will be available afterwards, so feel free to just listen and think of questions and respond to the poll questions without being worried about taking too many notes. And also, you are welcome at any time to use the GoToWebinar control panel to submit questions. And we'll be monitoring that throughout the webinar and also have a Q&A session, time permitting, at the end of the webinar. Okay, so why is this an issue that we're all concerned about? According to this study of 570,000, and there's a missing zero there, but 570,000 elderly long-stay nursing home residents over a 5-month period found that 37% of hospitalizations could have been avoided. And these are situations that could have been treated in the nursing home or prevented altogether. And as we all know, this is an important issue from a quality of care standpoint, and also it's going to impact the bottom line. And so, especially in cardiac situations, which is one of the most common cases of these rehospitalizations, it's something that more and more long-term living facilities are paying attention to more than ever before. And as you probably all know, even though the information is sometimes difficult to come by, starting in 2017, all guidance suggests that Medicare reimbursement rates will be based on quality metrics, including return visits to hospitals. So hospitals will be more likely to refer patients to rehabilitation facilities and long-term care facilities with better records of avoiding these rehospitalizations. And again, the financial impact is going to be quite substantial. So if I could have Dr. Mason give a brief overview of some of the cardiac situations or other symptoms masquerading as cardiac situations that can lead to these unnecessary hospitalizations.
Thanks, Colin. I think this is obviously the most important point that we need to understand in this seminar. The majority, I believe, of cardiac-related hospitalizations of patients going from nursing home to the ER or for admission, the majority are preventable. Probably the most common one is chest pain, and as we all know, most chest pain is non-cardiac in origin, although we also all know that chest pain has to be considered a cardiac problem until that's ruled out. And the electrocardiogram can go a very long way toward doing that. And I think of all of the uses of the electrocardiogram in the nursing unit, the nursing homes, this is probably going to be the most important one. Another very common issue is heart rate related. The heart rate's fast, the heart rate's slow, or it's irregular. It may be causing symptoms and we don't know why. Oftentimes that leads to a trip to the emergency room, but with electrocardiography available on site, almost every one of these heart-related issues can be properly diagnosed, and in most cases we may see that we've got a simple bradycardia, slow sinus rate, and we just need to reduce the beta blocker dose, or we have a patient in chronic atrial fibrillation whose rate is higher than usual, and we just have to increase the digoxin dose. In most cases, we prevent the transfer to the hospital. And then the third area that I think is common is unexplained symptoms and signs which could be cardiac related and for which an electrocardiogram could help a great deal in resolving the issue. And these include dyspnea, hypotension, reduced level of consciousness, syncopal spells, palpitations, and the like. And in many of these cases, having 12-lead ECG data available will clarify things and keep the patient in bed. So those are the main ones. I'm sure the rest of the folks in this call can think of quite a few more.
Sure. Okay, thank you. Well, what I'd like to do is ask our first poll question of the audience now, and it's going to relate to how people handle these sorts of cardiac situations. And it's related to, do you have a nurse practitioner or cardiologist available? So if attendees could select one of the following answers. You have one of these on staff and on site 24/7, on site part-time, available by phone, or do not currently have. So we'll let that. Yes.
Colin, by nurse practitioner, I assume you're talking about a nurse practitioner that specializes in cardiology.
That's right.
Okay.
Okay, we're getting some answers coming in here, and it's interesting. It's a third for on-site part-time, a third available by phone, and a third do not currently have. So far, we're not seeing anybody that has one on-site 24/7. Okay, we'll close that poll. So that's interesting. So that's my experience too. I don't see a lot of facilities that have this sort of cardiac care on site 24/7. So some of the next questions that I think are interesting to get into, and Deb or another panelist could jump into this. These questions, if anybody that's attending would like to respond to this and could type their answers into the question chat area of the webinar, that would be great. But Deb, can you, Deb, could you talk a little bit about the importance of these?
Sure. I think that every post-acute facility needs to establish a relationship with their hospital so that, it's a partnership in this goal to prevent rehospitalization. We know that by doing root cause analysis on these rehospitalizations, we can really drill down to find out the etiology of what happened. And our assessments that we're talking about, the ECG and other clinical protocols, putting those in place can really help drop that rate. They're actually, CMS is doing this with 7 organizations right now, and in March 24th of 16, they actually are developed and have allowed a payment system to go to the organizations that are involved in this pilot program to provide funding for this kind of a treatment and assessment of acute change, so that we can provide those kinds of intensive services like ECGs, IVs, blood draws at a, those are costly to some facilities to maintain 24/7. So it's a very important project to have on board, and CMS recognizes that and has established this program.
Excellent. So Liz, could you talk about some of the ways of avoiding hospitalization and some of the areas that you've seen that are important that keep coming up?
Sure. Thanks. I think I'm looking at your slides here, Colin, and seeing if they're, I see the poll questions right now. So if it's, opportunity to advance to the next one, I think.
Okay.
There we go. Great. Just to build on a few points that Dr. Mason shared, and a little more kind of look into Medicare beneficiaries in particular, just a couple points just to kind of frame up our thinking around this. But we know that hospitalized Medicare beneficiaries that are discharged home are 10% more likely to die within a year. So that's all cause, or the most common causes, I'm sorry, here that are in reasons that they're hospitalized. And people with these conditions, just based purely looking at the data, we know that a hospitalization for one of these conditions increases their risk for dying. What becomes even more troubling is when, if we see those same Medicare beneficiaries go back to the hospital within 30 days of their discharge, that the statistics show that they're 3 times more likely to die within the year. And we know that, again, this is based on Medicare data, but we know that some of the most common readmissions to the hospital, so I think Dr. Mason talked about the things that send somebody to the emergency room and those symptoms that send them to the emergency room. This number is based on people who are actually then from the emergency room admitted into the hospital. And so things like congestive heart failure, pneumonia, and acute MI are still kind of those top 3 reasons that we tend to see. So just the impact from a care perspective is really significant for an older, frail person and their ability to successfully get back out of the hospital and go back home, and not to even mention, what happens after they go home and try to achieve, a new quality of life after a condition like that. So it is significant. I don't know if we could go just to the next slide, Colin. I just had a couple of data points I thought I'd share with the group as well. Unless, I'm sorry, did you want to go to a poll question?
We can come back to it. No, go ahead.
So I think it's good, and we work with a lot of clinicians across the country, and so I get the opportunity to see some of the trends, and I think that the research here and some points that I wanted to point out are consistent with the conversations that I'm having with chief nursing officers and vice presidents of clinical services for different organizations. We know that reimbursement is moving from a volume-based reimbursement structure to value-based reimbursement structure. And as you mentioned, as Colin mentioned before, about that link between, or that impact that we're going to see on reimbursement related to quality metrics is really significant. So for providers that are trying to figure out how to get their arms around this and really look to see, okay, where am I going to be able to make the most inroads in impacting my reduction in hospital rates? When you look at some of the data here, we know that the American Heart Association shares with us that heart failure, just people with heart failure will increase by 46% in the next 15 years. So we know we've got this big wave of baby boomers coming that probably won't need long-term care or even assisted living for about another 15 years or so. Many of them are just turning 65 now, and we're seeing people wait to enter into assisted living and needing long-term care services kind of later in life. We know that the average age of skilled nursing residents today is around 87 years old. And this was a statistic as well. I think that kind of aligns with the research point that you had before, Colin, which was somewhere between 27 and 43% of return to hospital visits are tied to heart failure. So we know just heart failure alone is both increasing in prevalence, and the impact of that is significant. I think another interesting point is that the American Heart Association has is that 51% of all cardiovascular surgeries are done on people that are 65 and older. So we're seeing, that older generation of residents and patients really are the ones that are being most impacted by having lived with their cardiac condition for some time. And we also have some data that shows us that older Medicare patients with cardiac conditions that were in the hospital for a cardiac condition, if they need to go to a skilled nursing facility afterwards, that 30% of them have had an MI, 25% of them have heart failure, 20% of them have had a valve replaced, and 11% have had a CABG procedure, coronary artery bypass procedure done. So we're seeing the types of residents coming into skilled nursing facilities having more of these cardiac conditions as a whole, and so being able to really kind of get our arms around what we can do to help take better care of those residents. I think a lot of providers are really focusing on that. So, Colin, did you want to go back to the poll question, or did you want me to?
Yeah, well, let's I think just wrap up this thought with what the goal of this cardiac care program is in a skilled nursing facility.
Sure. So we're working right now with some providers on, that as they're building out cardiac care programs, we're really looking to help them, and I think this kind of sums up, I think, what I'm seeing in trends and in focus and programming is really to maintain cardiovascular stability, improve strength, endurance, and regain independence and return home if possible. Now, we know that's not possible for everyone that comes into our communities. And for those that are going to be with us for long term, or if there's we're looking at more palliative care, that we've got the opportunity to introduce hospice or palliative care in a very person-centric way for those residents that don't have the opportunity to get back home.
Wonderful, thank you. Deb, I know you're also very passionate about cardiac care programs, and you teach that. Is there anything you'd like to add to what Liz is saying here?
Just to dovetail that there is a high rehospitalization rate with these types of heart failure and pneumonia patients, as well as UTIs and dehydration. In fact, the MMRR study that was published in 2014 found those the highest. There are simple things that we can do in our acute care, post-acute care facilities to keep residents stable. So I think the takeaway point here is not only the recognition, which requires some staff training to identify when an acute change occurs, but also then what tools do we have in our toolbox within that facility to treat that acute exacerbation. And we're talking today about important tools like an ECG that will provide a physician or a nurse practitioner with great information and data to lend then to diagnose and treat that acute condition. And there are other things that we can do in our protocols and procedures to help us identify what is the acute change. But we definitely need to drill that down and use all our resources that we have and procedures to do that. And ECG, chest x-rays, IVs for potential dehydration, these are all great tools that need to be readily available with staff that are skilled and trained. So I think an important mention should be we definitely need staff competence in these areas and frequent review of these procedures that will help a resident stay in the facility.
Colin, it's Jake. Could I comment here?
Please.
Just a point that I'd like to make, because this is an area where I see deficiencies, and that is the fact that we'll take heart failure for example. There is very ample evidence that a team approach to heart failure management is very effective, with the team having multiple layers, including physician, nurse practitioner, and others. And the team keeps constant attention to, monitors the patient on an outpatient basis. But what I've seen happen is when that patient enters the skilled nursing facility, the team is basically lost to that patient, or the patient's lost to the team. And I just suggest that this is an area where we need to find ways to establish continuity in the team approach and have the nursing facility become a member of that team.
Excellent, great point. Well, and as part of that, taking ECGs, it's come up a couple of times. So I'm curious, we'll launch this poll now. How do you take ECGs now? So attendees, if you could please respond to this quick poll. Do you use a mobile provider, somebody that you call up and they come out in the van with the ECG device and take that? Do you use your own ECG device? Do you send residents to the hospital in all cases where they would need an ECG, or if it's ordered by a physician, or you are doing something else? Okay, we'll give that a couple more minutes there, or a couple more seconds, I'm sorry. Okay, I'm going to close the poll, so any last voting would be great. Okay, so 80% of participants are using a mobile provider. None are taking ECGs with their own device. 20% are sending residents to the hospital. Panel, any comments on what you're seeing in this poll result?
I can speak to that just a bit. I think that seems pretty consistent with what we're seeing with some of our provider customers. And although I think that the movement into using their own ECG devices is quickly growing. We've seen a lot of interest in providers that are looking to bring that in-house. They're looking for ways to add that, as Deb mentioned before, as a tool in their toolbox, along with, and I think Dr. Mason's point was an excellent one, and we see that a lot as well, is that kind of loss of that team approach to care. And I think that taking a very targeted approach to how they're focused on caring for people with cardiac conditions, and how they're training staff, and how they're looking to build those tools. So I think this number is definitely changing, and we're starting to see more that are adding that to themselves.
Yeah, this is Rachel talking. I also noticing the mobile provider coming from a SNF or a long-term care setting, as we are using the Spaulding medical ECG machine. Just the struggles of the mobile providers not being able to provide quick service when we're dealing with cardiac conditions. Obviously, we want to be able to establish that there is a problem and quickly. And a lot of times, the things that we have struggled the most about with using a mobile provider is the length of time between when we get the order, how long does it take for the mobile provider to get to us, and then how long does it take to get that read on the ECG back to us. And that has been a very long process and has actually caused hospitalizations in our facility, because when we're using the mobile provider, we couldn't get those results fast enough, and doctors just not comfortable waiting the length of time that it requires.
Yeah, interesting. Rachel will be speaking in a few minutes in more depth about their real-life situations at Cedar Community. So we'll dive back into that in just a moment. Okay, so going back to the slides here. So a cardiac care program. Liz, perhaps you could take us through some of the important elements that you see as part of a cardiac care program if it's implemented correctly.
Yeah, I think we've touched on a number of these things already, and I think in just what Dr. Mason and Deb and Rachel have already talked about here is that when I look at what I'm seeing and what we're seeing, providers who are really focused on this, adding or doing, and some of the trends that I'm seeing within those groups. These are some of the kind of the key things that I have just wanted to share with the group today. So for those providers that are focused on this, they're really defining out their scope of service, like what they plan to provide and what they don't plan to provide, and who's going to be a part of that on their team. Are they looking to partner with a cardiologist, with a nurse practitioner, with a cardiac specialization, looking to hire nurses perhaps who have some background in cardiac care from the hospital setting, or therapists that might have some cardiac rehab experience. So it is interesting as it's changing the way they look for staff and who they might be going after. Definitely seeing an increased focus on improving advanced directives and having that conversation up front about what the resident wants, and helping them and their family members to understand what the implications are for going back to the hospital, making sure that they understand what they're choosing, and that they're communicating that well with their providers. And the transitional care planning, I think, we're seeing a bigger focus on that, even with people coming out of the hospital, where they're really focused on, from even before they get into the skilled facility, is what the plan is to get them out, is to send them back home. So there is definitely more of a focus there that I'm seeing. We talked a little bit about staff already, staff education. We're seeing providers that are investing in providing more education, especially for their nursing staff. I was visiting a provider a couple weeks ago, and they had all of their nurses on their staff had gone through ACLS training, and just to improve their overall knowledge about emergency situations and how to respond. So even though they weren't going to be getting to the place where they were actually giving medications during a COVID event and that sort of thing, but it did help to elevate their overall knowledge level and improve their skill set there. I think the focus on interprofessional team management, back to it, and that working together as a team to provide team-based care is definitely something that we're seeing an increased focus in. Using exercise as a prescription. This is taking a page out of the cardiac rehab book, and we're seeing more working with their physicians to really treat exercise as not just the therapy that they might be receiving for therapeutic goals and treatments, but to how do we help older adults get more exercise into their day and make that a part of their life ongoing. As Deb mentioned before, the diagnostic capabilities, and we've already talked about the on-site ECGs and the ability to that stat service. Lab services, pharmacy services, same thing. We're seeing additions to programs where we're seeing smoking cessation training being offered, different classes that dietitians are offering, on nutritional changes for family members to learn too if they're taking residents home. And then definitely engagement strategies. This is a different model for skilled nursing when they're really looking at this transitional care planning and getting the residents involved early and their family members involved early in their care and learning about what it means to take care of themselves once they go home. So gone are the days of the traditional nursing home where we would see people come and live with us for the kind of the remainder of their lives. It's really a different model. And the last part is just emergency preparedness. Having the right equipment on in the community. If many providers are looking to add AEDs, they're looking at putting together different kinds of crash carts and putting different things in their crash carts and just taking a bit of a different approach to emergency preparedness. So these are all things that I'm seeing, that people that are taking a more focused approach to cardiac care that I think are kind of crucial to building out a good program.
Wonderful. Thanks, Liz. Would any of the other panelists like to expound on any of these points or add any other elements?
One thing that I would like to say, Mrs. Deb, is this is also an opportunity for cardiac telemedicine and other kinds of telemed innovations to be, put into a facility as finances allow. Most offices are more than happy to work with facilities to plan these types of things, and there are some grants out there for facilities. So that's always a possibility. Also, just to enforce that team-based approach Dr. Mason and Liz both have mentioned, working in a facility, there's, that 3 to 11 shift or midnight shift and someone gets acutely ill and the nurse is, alone in the facility and doesn't use perhaps the other nurses and supervisors to help make that call about that resident. And sometimes just calling in other resources at that time of night might allow a group think, a better outcome for that resident, a decision to wait until we can get the physician on the phone, and then make that decision to perhaps keep the resident for a few more hours. We need to remember nursing is nursing, and we sometimes need refreshers on the basic things that could help, providers make those decisions to not send a patient. Things like just I&O, how much fluids have they had? What's their baseline vital signs? Keeping track of their ECG over time, making a clinical picture that tells more, and not have that quick response, ship them out, we can't handle this at the facility, because, I know long-term care nurses can handle it, and they do it very well. And sometimes we just need to collaborate with each other, get that team decision, look at all the factors, help that resident stay to have a better outcome, because we've mentioned this rehospitalization to a resident is expensive, but more importantly, it's extremely disruptive to the resident, extremely disruptive, causing cognitive issues and medical issues and lots of change that a frail elder person can occur, just the trauma of transitioning them. So keeping, again, that team approach, helping each other make the best clinical decision, but going back and using those skills that the nurses have at those late hours to provide good data really will help make an informed decision. Thank you.
Excellent. Thanks, Deb. Rachel, let's turn it over to you. And actually, before I do that, I just want to remind the attendees that you can submit your questions in the GoToWebinar control panel, and we'll get to those. Or if there's a particular question that you have as someone speaking, we can try and flag those for them as well. For now, let's turn it over to Rachel to talk about how her community has been implementing a cardiac care program in their facility.
Yes, so Cedar Community started using the Spaulding ECG machine when discussing just wanting to be able to provide the best quality of care at the bedside for our patients, providing the best outcomes for our patients. And so we have really seen the ECG machine help us in many different avenues as far as people that are needing to get surgical workups, ECGs and things like that, being able to do that in-house, not having to send them out. But as far as reducing hospitalization when patients are coming in, being able to use the ECG machine to give the doctors a more complete picture of what is going on. We've had the success of, the chest pain. We are able to do the ECG in relatively minutes, send it over to the physician, and he has been able to read it quickly and realize that it is in a cardiac event. We've been able to narrow down what it is and prevented rehospitalizations in that aspect. But mainly just having the access of the machine and being able to do it so quickly in that bedside has just been very beneficial for our doctors to feel like we have kind of a step up above some of the other facilities around us who have to wait for mobile companies to come in and be able to get that ECG several hours after an event event or a change in condition. And so being able to do that in real time has really helped in the rehospitalizations, because a lot of times if we're not able to give the doctor what they need and give them the labs or give them the tests that they would like to see, they often want to say, let's send them back to the hospital, which is, like other panelists have said, not good for the patient, often disruptive, and usually does set them back from a physical standpoint as well as a medical standpoint. So that's where we've seen it. I don't know if anybody else has any ideas on that. Otherwise, I can go on to the ECG being administered by nursing staff. In our community, we've had several people trained and definitely have had really very little trouble working it. It's very small. Fitting in our hand, in the palm of our hand, which has been really nice as well. Our last ECG machine was on a huge cart, was very hard, cumbersome to move around, and so it's definitely training, I think, was only a couple of hours. I think it was only an hour actually for our staff, and several staff able to do it, apply the ECG with getting results that can be sent in pretty much instantly to the physicians for a read.
And just to clarify, the nurses who take the ECGs now were not previously trained in
Nope.
Specifically doing that.
Yeah, and a lot of them actually have also empowered them to do further learning for themselves as well, just being able to be a bigger part of trying to prevent real hospitalization, as CMS has that as being such a big goal for healthcare in general.
So you mentioned earlier about previously using a mobile provider for ECGs. Can you talk about the difference here in terms of time to get the ECG results from using a mobile provider versus doing it in-house?
Absolutely. So in previous times using a mobile provider, we were often placing the order, and there was times that they could not come out the same day. They would have to come the following morning. The other difficulties, sometimes not even being able to give us a time, but just a day. And when physicians asking for that ECG, they often want it rather quickly and want to get those results so that they can make a better educated guess as far as what we need to do from there. So obviously the time that it takes to first take the ECG has been quite delayed with our mobile provider, and then once the ECG occurs, we do get a printout, but the final reread from the cardiologist on the other end is often a day later almost. Which is really not appropriate in the setting that we're ordering as ECG, because there's something going on right now. That has differed significantly in using the Spaulding ECG, and the fact that you get the reading right on the iPad and you're able to upload it and send it to the physician within less than 5 minutes of taking it. You can have it over to the physician and dealing with the real life time and time sensitivity of the situation. So significant improvement in the ability to do it so quickly to reduce the rehospitalization, but also for the best outcome for the patient. Okay.
And you mentioned that you've also used an older ECG device that had the paper printout that was built in. What was the workflow like for that to get the physician to interpret that ECG?
Well, the difficult part of using the older ECG is just getting that information over to the physician as it prints out in that tape. Often faxing it would not work because they were unable to read the fax. It would come across too dark, and so we would try to take pictures of it and send it through secure channels, and it just was not. It was not benefiting anybody. I mean, the physicians were frustrated in the ability to not be able to read it, and sometimes too, because of the poor ability to read it, going over fax or what have you, they ended up wanting to send the patients out because they just weren't comfortable with being able to read reading the ECG.
Okay, excellent. Just to zoom out for a second, Jay, if you wouldn't mind just giving a kind of a layperson's perspective on how an ECG works. I know that's a big question, but some people that I've talked to have wondered about using a not a 12 lead but a fewer lead ECG, and why is 12 lead important, I guess, is the main question.
Sure. I think everyone's aware of the fact that there are quite a few devices, some of which can be implemented with an app in the iPhone, for example, that are capable of recording a single lead ECG. Basically, you're placing 2 electrodes somewhere on the chest, and you are in fact getting an ECG recording. These devices are fine, but only for limited purposes. Basically, all you can do with a 1 lead or a 3 lead ECG is determine what the rhythm is. And oftentimes, in complex arrhythmias, you actually do need the full 12 lead ECG to make that diagnosis. So the 3 lead or 1 lead devices are useful for rhythm detection only, and that really constitutes a pretty small minority of all the instances in which you need to get diagnostic information with the ECG. The 12 lead ECG as a small, portable, easy to use device is a new thing, and there are only a few options available. The Spaulding electrocardiograph is one of those few. And this, of course, provides you with all of the diagnostic capabilities of the ECG. It means that you can go beyond rhythm and diagnose acute ischemia, recent or old infarction, left ventricular hypertrophy, and the whole host of ECG diagnoses. So it's a very important distinction between the 12 lead and the limited lead devices. You need to know what you can get from them. Personally, I think that the 12 lead device is really so superior to the few lead devices that it's the only one I would consider using in a skilled nursing facility. The downside of it is that you have to place 10 electrodes in the right place, and that does take some training and a little bit of time, but it's not a huge barrier, especially in a nursing facility where nurses do have familiarity with the electrocardiogram, and even if they don't, can be trained to do a perfect ECG with maybe 20 or 30 minutes of instruction.
Rachel, would you say that has been your experience?
Yeah, definitely. We were able to train all the supervisors within a very short period of time, with Spaulding Medical coming in and doing some in-servicing with us. And then we did take that out further to our nursing staff who's on the floor, especially in our subacute units, as we try to reduce hospitalization and try to provide the best bedside care for our patients. And really a very small amount of questions, people really caught on to it rather quickly, and we've been using it for quite a while now, so with very good success. Actually, very good patients. It talks about rehospitalization.
Okay, great. And one further point on the ECGs, obviously when you take one, you need to have it read or interpreted by a cardiologist. And then I know our device and some others have computer algorithm interpretations built in. Jay, would you mind just sort of discussing what how you use that and to what degree those should be relied upon?
Sure.
How good they are?
Yeah, I think the most important message I could deliver on this topic is that if the onboard algorithm says normal ECG, it's a done deal because these algorithms are very good at detecting normal. But a normal ECG in octogenarians is a somewhat unusual thing. So in most cases, though you get a computer algorithm set of diagnostic statements, you really can't rely on them in many cases. I'm not saying that that's the case with all non-normal ECGs, but it is with many. And that means that having a physician available to look at the ECG is really important. Now, this physician does not have to be a cardiologist. Lots of other physicians are trained in interpreting ECGs, though I would say, maybe I'm a little biased, but I would say that cardiologists generally are more experienced and better at it. But ER physicians, family doctors, internists, anesthesiologists, lots of other physicians can read an electrocardiogram at a pretty high level of sophistication. So this means that just one last detail, that any system that a nursing facility decides to use for electrocardiography really should have a reading service associated with it, either one that's provided by the device vendor or one that the nursing facility can set up with local providers. That's critically important.
Yeah, that's a good point. And that was actually our last poll question. I brought it up on the screen, although I recall from the earlier poll question that none of the attendee facilities were taking ECGs in-house. So this is not one that you necessarily need to answer here, but it gives a sense of some of the options here. You could have an attending physician. You could have a relationship with the nearby hospital's emergency room. There could be a group reading service, some other method, or maybe you don't have them interpreted. So those are some of the options that I think you were alluding to, Dr. Mason.
Right. And even if some of our attendees aren't doing local electrocardiograms, I'd be very interested in their responding to that poll, because
there you go. We did get some responses, and here's what we were seeing.
Okay. So that's interesting. The attending physician is most commonly the reader for these ECGs, and that's good and bad. It's good because the attending physician oftentimes, hopefully almost all the time, has some awareness of the patient's medical conditions. And the attending physician is known to the nursing staff. So those are positives. But the negative here is that it's not often easy to get that attending physician in front of the electrocardiogram promptly, especially in the evening or weekends or holidays. And oftentimes the physician is, perhaps he's out at a movie or having dinner, and he's got to get himself somewhere where there's a fax machine to have the ECG faxed. So it's awkward, and the delay is a critical problem. This can be mitigated by involving attending physicians in the electronic reading process, which means that the attending physician could have access, just like our cardiologists do, to the ECGs, which he or she could look at with a handheld device or a computer. And that is something that device providers and reading service providers can and in my view should offer. The opportunity for attending physicians at the facility to be trained to use the electronic reading system and thereby be able to respond more quickly.
Excellent. Well, we have just a couple of minutes here. So again, I want to remind the attendees to submit their questions at the GoToWebinar control panel. And please note if you'd like to address your question to a specific panelist. One of the earlier slides had this question, and it actually did get submitted too, but just the idea of doing sort of a longitudinal taking of ECGs. Like, obviously in the elderly population, like you mentioned, Dr. Mason, ECGs often are not a normal result. And so what is the benefit of viewing multiple longitudinal sort of serial comparisons of ECGs in terms of assessing the seriousness of a current situation?
It's hugely important. 9 times out of 10, you do an ECG in an elderly person and you have an abnormality which may be a seemingly clinically dangerous finding. But you look back on the last 10 ECGs over the past 5 years and they all are exactly the same, and thereby avoid a panic transfer to the hospital when there's actually no electrocardiographic change. Many abnormalities on the ECG really shouldn't be interpreted without the ability to compare with previous ECGs. So I think that's an absolutely mandatory element in an ECG service at a skilled nursing facility. The ability to look at archived ECGs from the past, ideally in an electronic web record, rather than the usually vain search for the pieces of paper in the patient's chart.
Excellent. Last question came in, and it was directed to Deb about good sources and resources for additional information. Is there anything that you particularly recommend?
Is that question related to literature on this subject, or prevention through protocols? I mean, the Agency for Healthcare Quality and Research, NIH, CMS, Institute for Healthcare Improvement, all have tools and protocols to help post-acute care. And NADONA's website has fantastic resources to train staff on improving their standard of care and assessment processes. So
wonderful. What is that URL?
I'm sorry, the NADONA website, nadona.org. That
okay.
would be a good one, or the Agency for Healthcare Quality and Research. Even if there's information out there on CMS's website, and has wonderful resources, and they're all free. Especially, important is infection control, prevention, and the cardiac resources that we're speaking of today.
Excellent. Well, we are at the top of the hour, so I do need to wrap up. Thank you so much to all the panelists for your expertise and time today. I know the attendees, and I really appreciated learning from you. And attendees, thank you for joining today. And while we wanted to keep today's session at the educational level, as a thank you for attending today's webinar, Spaulding Medical is offering 25% off of your entire order. That includes our 12-lead ECG device with the web ECG software. So when you factor in those costs, it's a pretty good deal on top of what we think is already a pretty great deal on our device and software. So if you want to take advantage of that, you just go to spauldingmedical.com and enter the code webinar25 at checkout. Thank you again, and a recording of this event will be posted to that website later today. That's spauldingmedical.com, and we'll see if we can make sure that that gets emailed out as well. All right, well, that will wrap up today's session. Thanks again, and feel free to anybody reach out to me directly if you have any further follow-up questions. Take care. Bye-bye.